Greetings, everyone. Stephen Rahm with the Center for Emergency Health Sciences. I hope you guys all had a great week. It's a nice, beautiful Saturday morning. So I figured I would record this session on bundle branch blocks and paced rhythms. This session is kind of a continuation of a discussion that we had earlier in the week, the webinar that we did with Captain Miracle down at District 2 Fire Rescue on the near screening tool that Dr. Manifold would like for his agencies to use in the decision scheme for declaring HART alerts within our agencies. Part of that near screening tool has us differentiating narrow versus wide QRS complex rhythms. And the reason being is because we are having some medics in our agencies that are calling HART alerts on patients with left bundle branch blocks and paced rhythms. And many of these folks are ending up not having culprit arteries, not going to the cath lab. So we're overcalling some of these very specific patients. During the conversation that we had during the webinar, rather, I asked a question of what we believe our agencies, what we believe our foundational knowledge to be in recognizing bundle branch blocks at a baseline, specifically left bundle branch block, but bundle branch blocks in general. And the reason why I asked that question is because part of the near screening tool, the first component of that is if the QRS complex is narrow, that being less than 120 milliseconds, then I think that kind of gives the vibe that right off the bat, we would not activate a HART alert on that patient. Now, I can say that with left bundle branch block, that's obviously more so the case, but I couldn't really say that with right bundle branch block because a right bundle branch block often does not confound an underlying STEMI like a left bundle branch block does, for the simple reason that with right bundle branch block, you would not expect there to be any ST elevation. So any ST elevation with a right bundle branch block would make you really, really suspicious, especially if the patient has signs and symptoms of ACS, that it could actually be the real deal, versus a patient with a left bundle branch block in which you would expect to have ST segment elevation. So I know Dr. Manifold's intent of the near screening tool is to use as a supplement to our regional HART alert criteria with the overall goal of improving and increasing our accuracy in correctly identifying these time-sensitive patients in the field, but at the same time, reducing the number of overcalls, especially when we're looking at a left bundle branch block and we're calling it a HART alert simply because it has a left bundle branch block. So thank you for tuning in this morning. We're going to get through this fairly quickly. I'll have my email address at the end of this presentation. If you have any questions, I encourage you, please feel free to reach out to me, and I'm here to answer any questions that you may have. So let's jump right in. So before you can even entertain the notion that you're looking at a bundle branch block on an ECG tracing, there must be two prerequisites, so to speak, that must be met. Number one, the underlying rhythm must be of an origin above the ventricles. It must be supraventricular, and it could be a sinus rhythm, could be an atrial rhythm, like an ectopic atrial tachycardia, or it could be a junctional rhythm. It just has to originate above the level of the ventricles. You cannot have a bundle branch block, for example, with a ventricular rhythm. And I have several EKGs in my archives of wide complex tachycardias in which the computer interpretive statement said ventricular tachycardia, probable left bundle branch block. And I kind of got a giggle out of that because that's not possible. In order to have a ventricular rhythm, you can't have an underlying supraventricular rhythm. So I guess that would make it a supraventricular ventricular rhythm, which is a tongue twister in and of itself, but it's not anatomically possible to have that. So a bundle branch block must be born with an underlying supraventricular rhythm. So that's predicate number one. Predicate number two is the QRS complex must be greater than or equal to 120 milliseconds. Without these two criteria, you cannot look at that rhythm and diagnose it as a bundle branch block. So on occasion, we see EKG rhythms in which the QRS complex is somewhere between 100 and 120, and it may have a bundle branch block morphology to it, but it hasn't broken that 120 millisecond threshold. So in that case, your computer interpretive statement can say a myriad of different things, anywhere from incomplete bundle branch block to non-specific intraventricular conduction delay to a whole bunch of different things. So before we can even look at a bundle branch block, we have to make sure that the rhythm meets these two basic underlying criteria. A right bundle branch block, as you can see on your screen, occurs when the fascicle of the right bundle, there is a block somewhere in that fascicle. So, and I'm hoping you guys can see my mouse cursor up here on the screen. So we are going to assume that the rhythm would originate from somewhere up in this area right here, somewhere above the AV node. And then the impulse would travel down the AV node, the intranodal pathways, intraatrial pathways, into the common bundle of His, and it would get to this point and this point at the exact same time. So what happens with a right bundle branch block is, as electricity stops right here, it continues down the left fascicle. So with a right bundle branch block, the left ventricle depolarizes first, which means your initial force is from right to left. Initial force is from right to left, because nothing is going to depolarize down here via the normal conduction pathway when there's a block above that level. So the initial force in a right bundle branch block is from right to left. Then the terminal force, and this is going to be a key term here, terminal force is from left to right. So what that simply means is that you can see I put my leads V1 up here and then leads 1 and V6. So when I say terminal force, I mean the terminal wave of that electrical force in a right bundle branch block is going to be from left to right. Now remember the property of automaticity that the heart has. It has the ability to generate and conduct and propagate electrical impulses on its own. So that's essentially what's happening with this terminal wave, or this terminal force moving from left to right, is cardiac depolarization is happening by direct cell-to-cell transmission. But if you'll notice, that terminal force is coming directly towards the V1 lead. So what that means is, if you look in lead V1, you're going to have a terminal R wave. A terminal R wave. In other words, the QRS complex, and I use that term very generically, the QRS complex in lead V1 is going to terminate with an R wave. You can have a small Q and a big R. You could have an RSR. You could have several other variants, but the point is that it will end in an R wave. And I'll show you some examples here in just a second. For the same reason that you have that terminal R wave in lead V1, you have slurred S waves in leads 1 and V6, because as you can see, the terminal wave is moving away from those two particular leads. So this is what a right bundle branch block would look like. So there are a couple of methods that I think we've learned in our paramedic training and perhaps post-paramedic training and recognizing and identifying bundle branch blocks. And one of them was the turn signal method, right? So if you're driving in your car and you want to make a right-hand turn, then your turn signal would go up. And what that has given some people the impression of is that with a right bundle branch block, for example, if you're driving in your car and your turn signal goes up, then all of V1 would have to be up. In other words, V1 would have to be overwhelmingly positive. And while that is true in the vast majority of right bundle branch blocks that we will encounter, that turn signal method is not as conclusive as it could be, because it's actually the terminal wave of that entire complex that's pointed up. So in addition to that turn signal method, what I teach my students is, if you put a horizontal line right through your baseline, your isoelectric line, and right through the entire complex of lead V1, and then generally just to the left of the J point, and then you look for the first complete triangle that you make. And if that complete triangle that you make is pointed up, then you have a terminal R wave. In other words, that complex terminated or ended in an R wave. So as you can see in this example, I put a red horizontal line through the entire QRS, and then the first complete triangle that I made was pointed up. Therefore, this is a terminal R wave. It's actually a small Q. You can see the little tiny Q wave and a big terminal R wave. If you look out here in leads 1 and V6, you can see these terminally slurred S waves. So again, the same reason that you have a terminal R wave in lead V1 tells you that the terminal force is coming towards V1. That terminal force will also give you those S waves in 1 and V6 because the terminal force is going away from them. So this is a right bundle branch block. What's normal with a right bundle branch block? Well, if you look at leads V1 and V2, and a couple of examples I'll show you here in a second, it shows it even better. There is some ST depression in those leads. This is a normal finding with right bundle branch block. With any bundle branch block, you have an abnormal depolarization, right? And if you have abnormal depolarization, then you're going to have abnormal repolarization. So with a right bundle branch block, it's expected, it's normal to see some right precordial ST segment depression. By right precordial, I mean leads V1, V2, and V3. Here's another example of a right bundle branch block. This shows a classic RSR pattern in lead V1. So if I were to draw a horizontal line from my baseline all the way through that QRS complex, the first complete triangle I would make is pointed up. Therefore, this tells me I have a terminal R wave. If you look out here in leads 1 and down here in V6, kind of a small S wave out there in V6, but you can see it's kind of slurred. And it's obviously more slurred up here in lead 1. So again, another example of a right bundle branch block. Now, if you pay attention to leads V1, V2, and even so much a little bit here down here in lead V3, you see that ST depression that I was talking about earlier, simply a secondary repolarization abnormality. So one could not say that in the setting of a right bundle branch block, ST depression in V1, V2, and V3 would be an ischemic change, because you would expect to see that with a right bundle branch block. However, you would not expect to see any ST elevation with a right bundle branch block. So ST elevation with a right bundle branch block should make you go, there's something about this bundle branch block that's just not normal. It's up to you as a clinician to determine what's not normal about it. But what I can tell you is that ST depression is a normal finding in a right bundle branch block, specifically in V1, V2, V3. This example shows what's called an R prime in V1. And you see this little initial upstroke R wave, and then a prime into a second phase of that same R wave. This is often called, incorrectly, quite frankly, an RR prime. And the reality is these are not two separate R waves. In order to have an RR, you would have to have an intervening S wave in between. So if this little R wave had come back to the isoelectric line and dipped back below the isoelectric line, then you would have an RS. And then if it primed up into your second R, then you'd have a true RSR complex. But this is not an RSR, this is simply an R prime. But if I were to draw a horizontal line through this entire QRS complex, and again, I use QRS very generically, this is clearly not a QRS, the first complete triangle that I would make is pointed up. So therefore, this tells me this is a right bundle branch block. It has a QRS of 144 milliseconds. The underlying rhythm is sinus in nature because you can see P waves down here in lead 2. If you look out here in 1, you can see this really, really wicked slurred S wave, and same thing down here in lead V6. And again, here's that right precordial ST depression that we talked about earlier. This is simply a secondary repolarization abnormality. So this would just simply be a quote unquote normal right bundle branch block. This would be an example of an abnormal right bundle branch block. And if you look at this for a second, if you look at lead V1, you have a very small Q wave, and then you have a terminal R wave. So if I put a horizontal line through this entire QRS complex, the first complete triangle I would make is pointed up. So there's your terminal R wave. If we look out here in lead 1 and down here in lead V6, we can see these terminally slurred S waves. But remember, ST depression in lead V1, V2, and V3 is normal for a right bundle branch block, which means no amount of ST elevation should ever be normal for a right bundle branch block. This is clearly a pattern of LAD occlusion. You can see ST elevation in V1, V2, V3, V4, and you can see some reciprocal changes down here in leads 2, 3, and AVF. So this is where what I mentioned earlier with our near screening tool, if we were to literally take that screening tool at face value and immediately eliminate the potential for STEMI because the QRS was greater than 120 milliseconds, then theoretically, this is a patient who we would not call in the field. And I don't think there's anybody who's listening to this session today that would not call a heart alert on this. So it's expected that we use this in clinical context, with clinical correlation and pretest probability and all the stuff that we normally do when we're trying to identify a patient with acute coronary occlusion. So I can guarantee this patient did have an LAD occlusion. Fortunately, he did well, but this shows you a really good example of a right bundle branch block with a STEMI. So with a left bundle branch block, if you can imagine what we talked about earlier, where the terminal force is moving from left to right, with a left bundle branch block, the terminal force would be moving right to left. So again, we'll imagine that an impulse originated somewhere up here above the level of the ventricles. It made its way down the common bundle of his, and then it started traveling down the right bundle branch block, or the right bundle rather, unimpeded. But then when it started down the left bundle, then it ran into a block, which simply means that the left anterior and the left posterior fascicle are not going to get depolarized. So your initial wave, your initial force in this case is from left to right. The terminal force, however, is from right to left, unlike with a right bundle branch block where the terminal force was from left to right. So anytime the terminal force is moving away from your V1 lead, then you're going to get a terminal S wave in lead V1. Unlike with a right bundle branch block, the terminal force was moving towards V1 and you would get a terminal R wave. So with a left bundle branch block, you have a terminal S wave in lead V1. And because the terminal force is coming towards your leads 1 and V6 cameras, so to speak, then you would expect to see monomorphic R waves in those leads, as well as in lead AVL, because 1 and AVL are your high lateral leads, and then V5 and V6 are your low lateral leads. So really, you could actually more likely see a monomorphic R wave in leads 1, AVL, V5, and V6, but certainly in 1, AVL, and V6. So your terminal wave is going away from the V1 camera. So this is a pretty classic left bundle branch block pattern. And again, if I drew a horizontal line through my QRS complex up there in lead V1, you'll notice the first, in fact, in this case, the only complete triangle that I make is pointed down. So this tells me I have a terminal S wave in lead V1. And if I look out here in leads 1, AVL, and down here in V6, even in V5, you have these monomorphic R waves. And again, that's representative of that terminal wave moving towards those particular leads to give you that monomorphic, those monomorphic R waves. All right, so with right bundle branch block, ST depression in lead V1, V2, and V3 is normal, which means ST elevation with left bundle branch block is normal in leads V1, V2, and V3. And I'll touch more on that here in just a couple of minutes. So, and then again, here shows you the first complete triangle that I make is pointed down. So that's a terminal S wave in lead V1. Here's another left bundle branch block. If I were to put my horizontal line through my entire QRS, and you have this tiny, tiny little initial upstroke of an R wave. So this would actually be a little R and then a big S, but it does terminate, it does terminate into an S wave. If you put the horizontal line through here, the first complete triangle you would make is pointed down, so you have a terminal S wave. And then out here in leads 1, AVL, V6, even in V5, you have these monomorphic R waves indicating the terminal wave is coming towards those particular cameras. Another left bundle branch block, again, same pattern. I may be able to hallucinate a small little R wave in V1, but I can definitely see a little R wave down here in lead V2. So I'm just going to call these RS complexes, but you notice that it does terminate in an S wave, which means the terminal wave, the last wave of that complex, is an S wave. And then if I look up here in leads 1 and AVL and down here in V6, I have monomorphic R waves, but not so much in lead V5. There's not a monomorphic R wave in lead V5. So with a left bundle branch block, you would expect monomorphic R waves in 1, AVL, and V5, maybe in lead V6 as well. With paced rhythms, specifically right ventricular paced rhythms, and that's where, I think that's where most pacemaker wires are embedded is in the right ventricle. A right ventricular paced rhythm is going to assume a left bundle branch block morphology. And if you look up here in lead V1, you can tell that you have a terminal S wave. Again, if I put a horizontal line through this entire QRS, the first complete triangle I would make is pointed down. So this gives you a left bundle morphology in lead V1, V2, and V3. And we've historically been told that with left bundle branch blocks and with paced rhythms, you cannot diagnose a STEMI. And I will tell you that it can definitely confound the underlying diagnosis because you expect to see some ST elevation in those leads. However, it's not impossible to unearth an underlying STEMI with either a left bundle branch block or a paced rhythm. Here's another example of a pace rhythm. This is an AV sequential or a dual chamber pacemaker. You can see the pacemaker spikes before where the P waves are and then right before the QRS. But if you'll notice in V1, V2, V3, this assumes a left bundle branch block morphology because it does terminate into an S wave. All right, so let's talk about what is normal for left bundle branch block. I alluded to this earlier. We should expect to see some ST elevation. So what is normal? Well, if you look at this entire tracing, you'll notice that wherever the QRS complexes are going, the ST segments are going in opposite directions. And in other words, you have what is called QRS-ST discordance, and that is perfectly normal for left bundle branch block. It's one of those findings you would expect to see. And just look at the rhythm for just a second here. Where the QRS complexes are going, the ST segments are going in the opposite direction. That is QRS-ST discordance, and that is perfectly normal. If you look at leads V1, V2, and V3, which typically show discordant ST elevation, you'll notice that that is also normal. Right precordial ST elevation is normal. And this is where some paramedics fall into that trap of looking at those three leads in a patient who's having chest pain, and they say, oh, well, there's ST elevation. This meets our heart alert criteria because it's greater than 1 millimeter. So I'm going to go ahead and pull the trigger and call in the heart alert. Just remember that left bundle branch block is not in and of itself a STEMI equivalent. It used to be years ago, but it is no longer a STEMI equivalent. So if an individual did not understand or did not know how to interpret a left bundle branch block, then as you can imagine, they would call this a heart alert every day. And I think this is where some of the issues are, is that we're looking at these rhythms and we're saying, well, it meets criteria, so let's go ahead and call it in. Well, a lot of these people are not going to the cath lab. So if discordance is normal, if QRS-ST discordance is normal, and right precordial ST elevation is normal, then QRS-ST concordance would be grossly abnormal. In other words, a QRS and an ST segment that are going in the same direction. If they're going in the same direction, that's not what you'd expect to see with a left bundle branch block. Discordance is normal, concordance is not. So what this EKG is showing you is a pattern of appropriate discordance, a pattern of appropriate discordance. Now, let's look at a little bit of background on why left bundle branch block is no longer considered to be a STEMI equivalent. This was published in JAMA back in 2007 of a study that they did where they found that patients with new or presumably new left bundle branch blocks that went to the cath lab in this cohort of patients had an inordinately high prevalence of false cath lab activations. And in this case, almost half of the patients in this cohort did not have a culprit artery. And these were patients who were taken to the cath lab just on the premise that they had ACS symptoms and a left bundle branch block. So, and there are other studies that have been done like this, but then that led to the official demotion of left bundle branch block back in 2013, where we do not consider that in and of itself to be considered diagnostic of acute myocardial infarction. And if you guys will recall, prior to 2013, in our regional heart alert criteria, we had the signs and symptoms of ACS plus ST elevation of 1 millimeter or greater in 2 or more contiguous leads, or new or presumably new left bundle branch block. That has since been removed. So left bundle branch block in and of itself is not a STEMI equivalent. So then the question comes, well, if you have a patient with a left bundle branch block, how could you identify an underlying STEMI? I want to preface the rest of this conversation by saying that in our region, in our regional heart alert criteria, the Scarboza criteria are not factored in, which simply means that it's not expected that we would look at a left bundle branch block and try to determine what's normal versus what's abnormal. We just really need to know what's normal with left bundle branch block, and I think that and that alone would help reduce some of the number of overcalls that we're having. That being said, I want to discuss the Scarboza criteria because I do believe, and this is a validated method of looking at a left bundle branch block and a paced rhythm, by the way. It's transferable to a right ventricular paced rhythm, to be able to maximize our diagnostic yield, to be able to look at a left bundle branch block and say, hey, I see some concordant ST elevation. I wouldn't expect to see that with left bundle branch block. I am not saying if you see that, call in a heart alert. What I am saying is that you would want to relay that to the receiving facility in your radio report. If you are comfortable doing that, and if you are knowledgeable in the Scarboza criteria, so that way it lets them know that you are seeing something on your end that you would not expect to see with a left bundle branch block. So the Scarboza criteria are actually, they originated in 1996. Elena Scarboza is a cardiologist, and she and her colleagues, as part of this Gusto 1 trial, looked at all of these patients that had left bundle branch blocks, came into emergency departments with chest pain or other ACS or angina equivalents, and ended up going to the cath lab. And of those that came back that did not have a culprit artery, then there were certain things that did not show on that left bundle branch block. However, of the patients that came back with a culprit artery, she started noticing some patterns. She and her group started noticing some patterns, and she identified 3 specific patterns in these patients with left bundle branch blocks that corresponded fairly well with that cohort of patients who ended up having an acute coronary occlusion. So she published her findings in the New England Journal of Medicine back in 1996. In 2012, Dr. Stephen Smith and his group re-looked at her original criteria. And there are 3 components of this. And specifically, he looked at the 3rd component and did some modification to that, because I'll explain why here in just a few minutes, but her 3rd criteria turned out to be not very specific and not very sensitive, for the simple fact that she didn't take the rule of proportionality into account. And I'll elaborate on that here in just a second. So the Smith modification of the Scarboza criteria, which have been validated, by the way, are what you see on your screen. So in the presence of a left bundle branch block, and the same can be said for an RV paced rhythm because it will assume a left bundle branch block morphology, if there is concordant ST elevation in any one lead, except V1, V2, and V3. So when you're going through these tracings of left bundle branch blocks, you kind of have to ignore leads V1, V2, and V3 just for a second. And you're looking in any other one lead to see if there's a QRS complex and an ST segment that's going in the same direction. Because remember, concordance is not normal with left bundle branch block. And if you do see concordant ST elevation, is it 1 millimeter or greater? If you do find that, this is actually a very specific finding for acute coronary occlusion. The sensitivity is only about 40 to 45%, but the specificity is much higher, which simply means if the patient were not having an acute MI, you would not expect to see that. And that's simply what specificity is. So that's the first criteria. This is as Elena Scarboza originally published it. Dr. Smith revalidated it and said, yes, that is still a very specific finding in patients with left bundle branch block and acute coronary occlusion. The second criteria is when you turn your attention to leads V1, V2, and V3. So remember, in those leads, you would expect there to be discordant ST elevation. You'd expect the QRS complex to be going down and the ST segment to be going up. Well, if you were to see the ST segment going down as well as a QRS, then you have concordant ST segment depression. And if you see that, and if there's 1 millimeter or greater in any one of those right precordial leads, you don't have to see it in all three of them, just any one or more, that's also a pretty specific finding for acute coronary occlusion. Again, the sensitivity is not extremely high. The specificity is much higher than the sensitivity. Then the third criteria, this is the one that Dr. Smith and his group reworked and got revalidated and found that there was actually a higher degree of specificity with this third criteria, because Dr. Scarboza's original third criteria was if there is any excessive discordance, which she defined as greater than 5 millimeters. So where a QRS complex was going and the ST segment was going in the opposite direction, if the ST segment deviation was greater than 5 millimeters, then she considered that to be a relatively good predictor of acute coronary occlusion. As it turned out, that was the least predictable. So I'm going to bring up a little drawing tool here. I'm going to show you a couple of examples. So let's say that we're looking at this QRS complex, which is really, really deep, which you may see, for example, in leads V1, V2, and V3 with LVH. And I'm going to say that the J point is about right here where I'm stopping. And then I've got the ST segment right here. Okay. So we're going to put the J point about right here. So if that was 5 or 6 millimeters of ST elevation, that would have met Dr. Scarboza's original criteria. However, if you look at how deep this S wave is, and this is that rule of proportionality that I was talking to you about earlier, based upon the depth of the S wave, then 5 millimeters of ST elevation would really not be a lot. I mean, it's a lot, but relative to the S wave, it's not. In contrast to an S wave that's not that deep and and an ST segment that may only be elevated by 2 or 3 millimeters. So now based upon, I'll put my, I'm sorry, this is a crappy drawing here. I'll put my J point about right here. And now relative to the depth of the S wave, you have proportionally a larger amount of ST elevation. So it was this concept, this theory that gave rise to the modification that Dr. Smith made, which was if you look in any discordant lead and you see ST deviation that is 25% or greater the size of the QRS. So that could mean a QRS going up and an ST segment going down, or a QRS complex going down and an ST segment going up. Any discordant lead in which the ST deviation is 25% or greater the depth of the S wave or the height of the R wave, and what he called the modification or the ST to S ratio. So this is what the modified Scarboza criteria look like. I don't know that every physician is familiar with this. I don't know that every paramedic is familiar with this. I do know, in speaking with colleagues across the state and around the country, and some of their regional criteria, they are factoring in the Scarboza criteria. But as you can imagine, that requires a great deal of education, a great deal of practice. So for right now, let's just keep this as an educational component. When you look at those left bundle branch blocks, especially after you've delivered the patient to the hospital and you find out they did go to the cath lab, just kind of look around for any of these elements right here and see what you find. You might be surprised. So let's look at a couple of, this graph of this tracing right here shows you the 3 Scarboza criteria. So this is an example of concordant ST elevation. Notice the ST segment's going up and the QRS complex is going up. This is not normal for left bundle branch block. So you would expect in this case that if it was greater than 1 millimeter and the patient was having chest pain, there's a pretty good likelihood that if they do take that patient to the cath lab, they're going to find a culprit artery somewhere. So that's Scarboza A. Scarboza B is that right precordial concordant ST depression. And so remember, in V1, V2, V3, you would expect there to be ST elevation and not ST depression. But you can see that we have a downsloping ST segment with a negative QRS. So that would give you concordant ST depression in that lead. And again, it doesn't have to be in all 3, just either V1, V2, or V3, or any combination thereof. And then the third criteria is the modified by Smith, was the discordant or excessive discordance. So if we put our J point about right here and we measured the amount of ST segment deviation. So I'm going to peg this right at between 3.5 and 4 millimeters. And then we measured the depth of this S wave. And then we simply took the ST elevation millimeter number and divided it into the depth of the S wave. If the sum is greater than or equal to 25% or 0.25, then that would meet the definition of excessive discordance. Excessive discordance. Remember, discordance doesn't always mean QRS is going down. Discordance in this particular context is relative to where the ST segment is going relative to the QRS. So the example on the left, you see dominantly an R wave, but with some discordant ST depression. And in this case, you see 3 millimeters of discordant ST depression with a 10 millimeter tall R wave. So 3 into 10 would be 0.3. So that means that 30% of that R wave amplitude is the equivalent of that 3 millimeters of ST segment depression. So that would meet the definition of excessive discordance. The example on the right, you have predominantly an S wave. You have a little R, big S wave. So you have some discordant ST elevation because your ST segment is going up. And in this case, 3.5 millimeters of ST elevation as measured at the J point, and a 10.5 millimeter deep S wave. 3.5 into 10.5 gives you a 33% difference. So your ST segment elevation is 33% the depth of the S wave. So that would also meet the definition of excessive discordance. So let's look at a couple of tracings of left bundle branch blocks and some paced rhythms that actually did end up being acute coronary occlusion. So when we kind of look around this tracing, we're going to follow this in a lockstep method. Rule number one, is there any concordant ST elevation? Are there any leads, any one lead, remember, except V1, V2, V3, we have to kind of block that out for just a second, but do you see any QRS complexes and ST segments that are going in the same direction? And the fact is there are actually 2 leads. If you look at lead 2, you have a QRS that's going up and an ST segment that's going up. Down here in V6, you have a QRS that's going up and an ST segment that's going up. So right off the bat, this is not a normal left bundle branch block. This would meet Scarboza A, right, of concordant ST elevation of 1 millimeter or greater. But let's keep looking. Let's see if we find anything else that's abnormal. Scarboza B, look at leads V1, V2, and V3. Do you see QRS complexes going down and ST segments that are also going down? And the answer is yes. You actually see it in all 3 of those leads. Your ST segment is down here, your ST segment is down here, your ST segment is down here. Remember, if this were a normal left bundle branch block, there would be discordant ST elevation, not concordant ST depression. This patient did have a confirmed STEMI and did get some reperfusion in the cath lab. Here's another example of left bundle branch block. Excuse me. So again, we're going to follow this in a lockstep method. If we look at any one lead except V1, V2, and V3, do we see a QRS complex and an ST segment that are going in the same direction? And actually, if you look out here in lead V6, you can see that the QRS and the ST segment are isoelectric. In other words, the ST segment's isoelectric. That's okay, because in order for it to meet that inappropriate concordance, it would have to be elevated, right? You'd have to see 1 millimeter or greater of concordant elevation, and you don't see that down here in lead V6. So basically, we've learned nothing so far. So then, if I look at the other leads, I don't see any other leads where the QRS complexes and the ST segments are going in the same direction. So then we look for evidence of Scarboza B. So we turn our attention to leads V1, V2, V3. Do we see any one or more of those leads in which the QRS complex is going down and the ST segment is going down? And the answer is yes, we do. We see it down here in V2. You can see the ST segment is depressed below the baseline, giving you some concordant ST depression in lead V2. So again, that would tell you this is not a normal left bundle branch block. Third element, do we see any excessive discordance? In other words, relative to the size of the QRS, whether it's pointed up or down, when the ST segment's going the opposite direction, do we see greater than 25 greater than 25% deviance from the size of the QRS? And we actually see it in multiple leads. If we look in 2, 3 and AVF and look up there and lead AVL, so the J point would be way up here, and you've got probably a good 4.5 to 5 millimeters of ST elevation, which basically probably about 4.5 to 5 millimeters of S wave. So that would give you a ratio of 50 to 50%. So that easily breaks that 25% threshold. Remember, you only need to see that in one lead, right? But we see it in multiple leads. You see it down here in 3, a big time ST elevation. Same thing in lead AVF. And if you look at lead AVL, this R wave in AVL is only about 6 to 7 millimeters tall, but your J point is way down here, and you have almost 4.5, maybe 5 millimeters of ST depression. So this would mean that those leads are showing excessive discordance following the Smith modification, or his definition of excessive discordance. And this patient ended up with a right coronary occlusion. And I'm going to back up here for a second. If you look at where the pattern of excessive discordance is, it's in those inferior leads in 2, 3 and AVF with a reciprocal ST depression in AVL. So this patient had a left bundle branch block and had a 100% right coronary artery occlusion. What about paced rhythms? Well, we know that paced rhythms assume a left bundle branch block morphology if that pacer wire is embedded in the right ventricle. So we're looking up here in lead V1, and we have this terminal S wave, and we see some discordant ST elevation, which again is normal. But let's just go through it just for its and grins and see if we can apply the Sgarbossa criteria to this as well. So do we see any leads on this tracing in which the QRS complex and the ST segments are going in the same direction? So I'm going to give you about 5 seconds to look around. Just kind of look up, look down, look all around, and do you see any QRS complexes and ST segments that are going in the same direction? And the answer is yes, we do. We actually see it in 4 leads. If you look up here in lead 1, your QRS complex is going up, as is your ST segment. Remember, this is always measured at the J point. Same thing down here in lead 2, your QRS is going up, your ST segment is going up. Out here in V4, if this is not a hyperacute T wave, then I don't know what is. You can make this entire little tiny QRS and fit it underneath that entire T wave. That is a huge hyperacute T wave, but nonetheless, the QRS complex and the ST segments are going in the same direction. Same thing down here in lead V5. So this would meet Sgarbossa A of concordant ST elevation greater than 1 millimeter. So this patient this is a confirmed STEMI. This patient was having a STEMI. Here's another paced rhythm. Another paced rhythm. So we're going to follow the same path. We're going to look for any leads that are showing concordant ST elevation. And you can see that there are multiple leads, lead 1, AVL, V5, V6. You see that your QRS complexes are going up and your ST segments are also going up in all 4 of these leads. And again, this was also a confirmed STEMI. So before we close out here again, I want to just reiterate a couple of points, okay? So on the surface, when you're looking at a left bundle branch block, on the surface, you can't call a heart alert, okay? And that has been established in science. However, if you don't know what a left bundle branch block looks like to begin with, then you're going to call a left bundle branch block a STEMI. So the whole point of this was to make sure that we are solid with our bundle branch block recognition, both left and right, but as it pertains to the near screening tool and the reason for the number of overcalls, specifically left bundle branch block. And then ask yourself, am I looking at a normal left bundle branch block? If I'm looking at a normal left bundle branch block in which there's normally ST elevation, then we shouldn't be calling a heart alert on those folks, because chances are most of those people are going to have, they're not going to have a culprit artery. They're not going to go to the cath lab. So we've done an overcall. We've called in a lot of resources that are costing somebody a lot of money. However, if it's not a normal left bundle branch block, then I think a prudent move, it would not be unreasonable to at least let the receiving facility know that in your radio report. And as always, if there's ever any EKG that you ever have any question about as to whether or not you should call it or should not call it, then just take a picture of it and send it to Dr. Manifold. and have him take a quick look at it, and between the two of you come up with a decision as to whether or not you should pull the trigger. One last element here is this this idea of sending EKGs through the MedCon system for consult. You're looking at a funky EKG and it doesn't really meet heart alert criteria, or you're just not sure if it does. So and I've had conversation with Dr. Manifold about this before, he would rather us not send that through MedCom to the receiving facility for their consultation. He would rather us send it to him, so that way he can look at it. I think that's very reasonable. However, in that unlikely event that you have a physician on the other end who says, well, I'd really like to see the EKG before you get here, if you are going to send it forward, be sure and write right across that EKG for consult only. So that way, when you text that to MedCom and Manifold gets that on his in his text, he's going to see for consult only. He's going to know that you are not calling a heart alert. He's going to know that you sent that at the request of the receiving physician. That does not happen that often. Most of the time, even if you do send it, it's probably going to end up on their iPad. Nobody's going to look at it anyway. So, folks, I hope this was educational for you. I hope this this maybe tied up some loose ends, or if nothing else, it was just a really, really good review over left bundle branch blocks and right bundle branch blocks and pace rhythms, what's normal, what's not normal. If you ever have any questions, please send me an email. My email address is up here on the screen. I really appreciate you guys hanging with me here this morning, and enjoy the rest of your weekend. And I look forward to talking to you guys soon. Peace out.